record, I'm not sure I deserve all that, but I appreciate it anyway. Thanks, first of all, to everyone for coming. I know this is kind of that magical hour right before happy hour, and I want to make sure that we can get you downstairs on the dot at 5:59, so we're going to be very brief. And we're going to keep this casual, so conversational style. And I just wanted to start by mentioning up front my various conflicts of interest between myself and the panel. Alan LeBrick is from Johns Hopkins School of Public Health, and I was at Johns Hopkins in at least 2 different capacities, so there's that background. And USAID funds the other 3 people on the panel. They're all going to say, I'm going to say wonderful things about them, and they're going to say wonderful things about us. So take it all with a grain of salt. I just wanted to, first of all, just start by just providing a little bit of introduction. I think, for those of us who have been here for the last 2 days, we've all seen that there's been a lot of really neat things that have been demonstrated. And there are a couple of themes that I just wanted to mention very briefly that I see emerging that have become a little bit more clear to me this year as opposed to last year when we had the first summit. And kind of lay out some of the opportunities that I see that some of the other panelists may touch on. One of the themes that I'm seeing is kind of what I'm loosely calling, and I'm stealing this term from someone, I'm just not exactly sure who it is. If one of you, raise your hand and tell me. But it's the kind of the democratization and personalization of healthcare, of both healthcare consumption as well as healthcare delivery. And loosely speaking, what I'm referring to when I say that is that for the first time, individual patients and family members are able to access health information when they want it, potentially in a form that they want it in. And then healthcare providers, we invest a lot in training and supervising healthcare providers. Potentially we're seeing a move away from one curricula fits all to personalized curricula depending on a person's educational background, literacy levels, the speed at which they learn, that type of thing. So I think there's a lot of potential for us through mobile technology to fine-tune the way we reach people. One of the other themes that I see emerging is the whole theme of integration in many, many different ways. David is going to be talking about data collection, I assume. I didn't actually ask you beforehand, but I assume you will. But previously, data collection was its own thing, just collecting data, sending it up, and that's it. Story done. But now through mobile technology, we actually have the potential to communicate the results of the analysis of that data with the person collecting that data, potentially even in real time. Use data collection as for feeding into, for instance, pay for performance, and using data to, for instance, collecting data in the form of electronic health records. It would be very easy to integrate that into a behavior change program. So, for instance, Kelly is going to be talking about an information, education, communication program using cell phones for reproductive health. People have heard about Text for Baby, for instance. Right now, Text for Baby is a standalone program, but you could easily imagine that, one day in the future, when every woman has an electronic medical record, she goes in for her first antenatal care visit, and then the fact that she's pregnant gets uploaded to her EHR, and then she automatically starts getting those Text for Baby messages. And then if she, during her pregnancy, develops malaria, she goes in, she gets diagnosed, and now she starts getting malaria messages and malaria in pregnancy messages. And so it becomes a very seamless system between data collection, healthcare monitoring, and behavior change. Then the last theme I'll just mention, which is pretty obvious, but it deserves to be mentioned, is the ability for cell phones to allow us to communicate in real time over distance. And that's not something to be taken lightly. And my feeling is that there's a lot of really good things going on in terms of downloadable applications, even basic things like SMS. But if you were to ask me now, what right now is the killer app for mHealth, I would have to say it's making a phone call and speaking to someone, real time, live, with your own voice and hearing back a live human voice on the other side. And it's something that doesn't require any IT expertise. You don't need to have your organization's CTO come out and install something for you. You don't have to worry about literacy issues, and it's the kind of thing that I think really has a lot of potential to save lives. And if you think about the maternal and under 5 mortality, as Alan is going to talk about, maternal mortality, newborn mortality, there's certain critical events in the life cycle, pregnancy, labor, delivery, and then the immediate postpartum period. As well as through the under 5 years, there's certain things that women, newborns, and children die from. Infectious diseases, obstructive delivery, that type of thing. And if we can intervene with a mobile technology application at that particular point where it means the difference between life and death, I think we are going to see real change in terms of health outcomes. So I'm really eager to listen to the panel, even though I've actually heard all of their presentations before. But eager to having you guys kind of fire back some kind of penetrating questions to them and challenge them and encourage them to either be even more creative about the kind of work that they do.